Ponciano Kalibu, and followed by Dr. Mwanga. USF is incredibly lucky and pleased to have a partnership with these two physicians in Uganda. We have been able to visit them in their hospitals there, in Entebbe Regional Referral Hospital, which is a government hospital, and in the Ugandan Viral Research Institute, which is one of the leading research institutes in Africa. And they have been excellent, engaged, excited partners for USF to work with on quality improvement, on patient care, and on research. And so I'm going to first introduce Dr. Ponciano Kalibu. He is the director of the Ugandan Viral Research Institute, and he also is faculty at the London School of Hygiene and Tropical Medicine. UVRI, which is the abbreviation for the Ugandan Viral Research Institute. This is the largest government institution in Uganda for research. They are a COVID-19 reference laboratory for the WHO for Africa. They are also a center of excellence for COVID-19, certified by the US CDC and the WHO. They, before COVID-19, they worked with studying the HIV epidemic throughout Uganda and other areas in Africa. And they work on other emerging infectious diseases, including malaria, and even some that are not infectious. So Dr. Kalibu himself, he has his medical degree from Makerere University and also a PhD from the University of London. He's a fellow of the Royal College of Physicians of the UK and a fellow of the Academy of Medical Sciences in the UK. And Dr. Kalibu, thank you so much for joining us. We'll let you get started.
So thank you very much for that introduction and for this privilege to give this presentation. I hope I'm clear enough. Is this okay? Okay. So can we move the slides, please? So I'm going to talk about the public health response to COVID in Uganda. I'll give a presentation first, then my colleague, Dr. Mwanga, who has been at the center in one of the large hospitals here in the country, will also present on some other areas. But I think the most important to note is that we have been able to respond as a country because there's been some preparation before. And I've listed here some of the key areas that have been quite important in addressing other emerging infections. The investments that the country has put in preparedness efforts to address the global health security agenda were quite important. This coordinated and organized multi-sectorial response to public health emergencies. Stronger country and Ministry of Health leadership was very key, which facilitated this coordinated approach. Then the leveraging the strength of partnerships. The partners have been quite important, and there have been multiple partners that have made a contribution in our response. I've just listed here on WHO and Africa CDC, but there are many others. Effective contact tracing and alert management, real-time surveillance with a lab hub system able to collect samples from different places, the National Task Force, and of course the Scientific Advisory Committee that was set up by the Ministry of Health, to which I'm a member. Next. Here I've listed the figures and of course they're quite small. They may not be easily visible, but to give you some idea of what have been the key events that have taken place over the period of time since COVID was first realized, even before we first identified the first positive case. On the 18th of March this year, there was a suspension of mass gatherings that included closure of schools, churches, markets, that happened quite earlier on after hearing what was going on in other places of the world. We had our first case on 21st of March, and that case, this testing was here, and the case came from the Entebbe Hospital, where my colleague Dr. Mwanga is the director. And since then, and from that time, a number of events took place. I won't go into all the details, but there was a lockdown on the 30th of March, whereby there was lockdown, there was curfew that was instituted in the country, restricted movements, people were staying at home for a period of time. And actually it was until around 26th of May that private cars resumed after about 2 months of nearly total lockdown. On the 23rd of July, unfortunately, I don't have a marker to clearly show because I'm not going to go through all these events, but I'm just picking out a few. On the 23rd of July, we got our first death, and if anybody can see that, it is just before the cases started rising. More cases, especially the local transmissions, and then they kept on rising. It's only recently, and then some unlocking, of course, went on happening. The school, some movement of cars. Now, as we speak, they have opened, some offices resumed, and on the 15th of October, the schools have been opened only for the candidate classes. But they still limited the gathering, restricted gathering in the churches and other places. So those have been some of the events from the very beginning, even before COVID was first recognized here. Next. The other highlights that I want to mention, by 25th of October this week, we had a cumulative total number of about 11,557 cases, and about 101 deaths. That's a case fatality rate of 0.9%. About 88% of these are locally transmitted, while 12% are imported cases. The national bed capacity currently stands at about 3,752 beds, with about 366 cases on active admission by 25th of October, and that gives a bed occupancy rate of about 9%. So it's not too bad at this stage. With a cumulative total number of samples of about more than just above 500,000 samples that have been tested. Quite a big percentage of those samples have been tested here at the Uganda Virus Research Institute, but there are other labs that are also testing. Next. This slide just summarizes, just to show you a trend of how the events have gone since the 21st of March, when we first had our case. The numbers kept on increasing, but key to note here is the blue. Initially, we had imported cases, but those have remained low because of the lockdown, the closure of the airport, and then we started getting local transmissions. Most of the imported cases came from across our borders. I didn't mention, but our borders were also closed during that period to the neighboring countries, and there was very strict testing at the borders. And we saw a number of cases that crossed from the neighboring countries. But as you can see, when the cases, the rise of the cases in red, those are mostly now local transmissions that we are seeing, but very limited imported cases. Next. And this again summarizes the cases that we have. The type, a big percentage in green are contacts, and these are contacts of either the travelers in, the truck drivers, health workers, those who returned, and the alerts. The alerts comprise a reasonable percentage of about 35%. As I said, there's a very good system whereby suspect cases are reported to the center, and these are, of course, contacted, and they are they're evaluated, and eventually testing is done if that is warranted. So most of our cases here now, as you can see, are contacts of the other cases that we have. Next. I cannot go without mentioning the trends in health workers. We're all concerned about health workers. These are the people at the front line who are dealing with the COVID cases all the time from the very beginning. Of course, the country has done a lot to ensure that they are provided with PPE and all other supplies. But you can see that over time, we've had an increase of infections among health workers. The numbers are not so big, but of course, that's a concern. You can see on that graph, of recent, there's been some decline, but this is a short period. We need to see the trend to ensure that the number of health workers who are infected is not on the rise, because this is very key and it can disrupt our interventions. Next. And again, this one shows health workers. Those are small figures. You cannot see them, unfortunately, but the top where we have the largest number of infections is in the capital city of Kampala. Of course, it's not surprising. That's where we have the majority of cases now. That's where we have most of the isolation centers and the big hospitals that are handling our cases. Next. This graph, I just included it to show a comparison with the countries that are neighboring us. That's Kenya, which is blue. That has the highest numbers of cases that are rising. Rwanda in the south of our country has also the lines in gray. Burundi and South Sudan, which is in the north, and DRC, Democratic Republic of Congo, on the east of the country. There's one country, Tanzania, in the south of the country, where we have no information at all. We can't tell, but we know they have cases because the truck drivers from Tanzania have also tested positive. So Kenya has the larger number, but also for now, Kenya has the largest number of testing. Before, Uganda tested more, but Kenya has surpassed us in terms of testing. So you may find that if some of this reflects testing, but also, of course, the size of the country and the population. So that's the figure we have, but we are missing Tanzania, and we are also aware that this may not be reflecting the true picture of what is going on. Next. I want also now to talk a little bit about the testing that has been done. The initial testing was done at our institute here at the Uganda Virus Research Institute using our National Influenza Lab, which is a national and regional lab for influenza, and they had already the experience of working with the respiratory viral infections. And when COVID was described in other countries, they started testing, of course. Initially, they didn't have all the kits. But we were able to get some kits from WHO and Africa CDC, and we continued testing suspected cases until the 21st of March, when we had our first case of somebody who had traveled in from, I think, Dubai. The testing was a little at that time, but it increased from 20 samples per day to more than 3,000 samples per day, and we had to expand to other labs within UVRI to provide testing. So we provided all the testing for the country for the initial 3 months of the pandemic until other labs were also certified and started testing. Next. Next slide. As a national lab, we're a national and regional reference lab. We work with our partners, including the MRC, UVRI London School, and CDC. We do testing. We do accreditation of other testing labs before they start. We do test kit evaluations, PCR, antigen, and antibody. With COVID, there's so many kits that are coming into the country, but we're given the responsibility of ensuring that we validate them before they are used. Currently, we only use PCR, but we are soon recommending we have already recommended to start using the antigen, especially for quick, as a point of care, for very quick intervention. Antibodies for surveillance. We do sequencing of the virus using MinION sequencing, the Oxford Nanopore. We're members of different national and international committees. We have started actually surveillance activities using doing PCR, but also we shall do antibody. And as mentioned, we are a WHO reference lab and Africa CDC, a center of excellence for COVID. Next. Yeah, some of the challenges we're facing are the increasing numbers, of course. The numbers are increasing, it became too much, and we could not manage the number of samples that were coming. But the good thing, as I mentioned, more labs were opened, including labs at the borders where testing is done. As many other places, irregular supply of reagents and other supplies has been a big challenge because the whole world has been really going to sometimes the same vendors supplying some of these kits. And the cost and the reliance on PCR has been quite very challenging. Funding has been a challenge, but we're very pleased with the number of partners who have funded our testing. But staff, of course, we have staff fatigue, people are working 24/7. Testing, and of course we have to ensure that the quality of testing and more labs have to come on board. Next. But because of this and the workload, the government and the ministry has now started prioritizing so that we don't test everyone, but we really identify those who are symptomatic. There are labs that are opening that will be used after paying, but for free government. Now there's sort of focusing on those who are symptomatic and meet case definition, the contacts of the above cases and any other contacts at high risk, the frontline health workers, and also for surveillance activities. But as I've said, more labs are now coming on, including private labs. I hope this will reduce on this big challenge and burden, and also the introduction of antigen as rapid diagnostic tests. We hope this will also alleviate some of the challenges. Next. Many people are asking why the disease in Africa appears to be mild and the pandemic is not yet as predicted. There were some reports saying that 80% of Africans who are infected are symptomatic, but I think that number may be slightly overestimated, maybe slightly less. The others are saying that maybe we are not seeing the pandemic, the epidemic in Africa because there's less testing rates in Africa. There are also school of thought that maybe the age, we have a youthful population. As you know, only about 3% of Africans are over the age of 65. Could it be immunity to other related coronaviruses? Is it because of the early introduction, less flights, strict lockdowns in many African countries very early on had an effect on the spread of the infection? Is it the climate that is not very favorable to the virus? Is it the host genetic composition? All these are important research questions that we need to address, and we are trying to address to see why the pandemic. Of course, there are others who are saying that you wait, you are yet to see the epidemic may again overwhelm Africa. But for now, the pandemic has not been as this was predicted, and we need to find out the reasons why. Next. This slide just shows you the severity of the active cases that we have. As you can see, the majority have been asymptomatic, and for this figure, I think it's about asymptomatic about 47%. Many have been mild and moderate, and my colleague Dr. Mwanga is more conversant with all this. He has been at the center of it, handling. Then we have severe cases and the critical cases, and this was based on a figure of about 366 individuals. Again, to show you how the severity of the disease, the majority of our patients being either symptomatic or mild to moderate cases. Next. If you look at age, again, you can see that the majority of our patients have been below 60 years. Of course, this slide, I realized that the numbers put there, 101, the figure here, they're about 93, and I computed those who are less than 60 years, they are again, I think about maybe 50%, and that could be slightly different from other populations in the north, but yes, we see a number of young people below the age of 60, but we also see the old ones, 60 years and above, and the quite young ones. So the picture is mixed, but yes, indeed, we see a number of severe cases among those age groups below 60 years. Next. And this has been divided into male and female. As you can see, it's a predominantly male. We have more males who are affected and with a high mortality. Next. Some of the research questions that we're addressing next. I've listed here some of the research questions that we are trying to address here at the Uganda Virus Research Institute. We are sequencing the virus using phylogeny, and I have another slide that will talk a little bit about this. We're looking and trying to profile the immune responses from the time the patients are admitted up to 1 year to see how the immune responses appear and disappear. We're looking at IgG, IgM, and other antibody, but also we shall be looking at T cells and immune responses to understand more about these immune responses. And we shall be also looking at immune responses to other coronaviruses. We're doing surveillance, and there's one study that just started this week in a rural population, and also some sites along the Trans-Africa Highway, again to look, to survey, to find out what's happening, acute infections, and also past exposure, looking at antibodies. We are part of treatment. The INSA treatment and the clinical trials group treatment looking at monoclonal antibodies. Just yesterday, I think, one of the studies, one of the monoclonal antibodies was stopped. I think it was not showing much benefit, and we had not yet enrolled into these studies, but we are part of the protocols to look at these antibodies among those who are inpatients and those who are outpatients. We also want to understand COVID in pregnant women. We have funding to do that. Vaccine research. We have already started a study to look at knowledge and acceptability of vaccines among health workers, because there are lots of stories about vaccines, about using Africa as guinea pigs. So we need to understand the knowledge, how acceptable vaccines will be. We're also participating in vaccine design, and this has been through really the pressure and encouragement of the president to ensure that we participate in vaccine design. But we're also preparing to conduct a phase 1 trial using a self-amplifying RNA vaccine that has been developed by our colleagues at Imperial College in London. And we're also participating in the discussions within the Solidarity Protocol and the WHO and Africa CDC. And then finally, we shall also be part of the larger multi-center studies looking at the genetics, host genetics and disease severity of COVID. Next. Next slide. Yes, this I want to go into much, but phylogeny has helped us. We have sequenced, and our sequences have been deposited into the GSID database, but already I've circled, we had an outbreak of COVID in a prison. And when we went to sequence, we realized that again, there was a cluster of viruses that were very, very much related in this prison. And also were able to identify a potential source of the infection. So phylogeny has helped us. Phylogeny has also helped us from the beginning. We saw that the viruses that were introduced, we are matching the viruses of where the travelers were coming from. If a traveler came from Dubai, the viruses were matching those of Dubai. If a traveler was coming from London, they were matching. So it was helping us. And over time, the picture has been changing as we have local transmission. Again, our major lineages are B1 and A lineage of this coronavirus. Next. Finally, I cannot go without mentioning some of the challenges. Of course, the dispatch of results, and we are trying out the electronic laboratory request application is being rolled out so that results can be distributed as quickly as possible. We are seeing resistance from communities to be evacuated for confirmed cases, and Dr. Mwanga here knows more about this. Denial of results, non-compliance with directives and guidelines. There's still this feeling that some of them of our population about COVID. Is it true that COVID exists? Is it serious? So there are all those resistance that we need to address. Inadequate resources and funding to facilitate smooth operation of the different responses. And lastly, the procurement challenges, which I mentioned earlier, which is leading to shortage of testing kits. I think that's my last slide. I just went, next slide, to thank you all. And I think now I'll let my colleague, Dr. Mwanga, tell you more. He's been more into it at the hospital, and he has quite a lot to say. Thank you very much.
Thank you, Dr. Kalibu. And for Dr. Mwanga, I'm just going to take 1 second to introduce you as well as our excellent clinician and medical director for Entebbe Regional Referral Hospital. He's been at the hospital as the director for 14 years, and Entebbe Regional Referral Hospital is a critical medical center, and it is responsible for healthcare for 7 districts in the region, and is the designated referral hospital for COVID-19 cases for Uganda. To date, I believe Gloria updated us that you guys have had 450 patients treated at Entebbe Regional Referral Hospital, which is a very high number. That's a fantastic volume. So I'm sure that we're very interested to see, what you guys have been doing there. Dr. Mwanga himself also graduated from Makerere University. And in addition to being the medical director for the hospital, he also leads quality improvement projects nationwide, including the 5S Kaizen group that improves the organization of workplaces across the nation. And he is a collaborator with UVRI on several projects and with USF on some of those quality improvement projects. So Dr. Mwanga, take us away.
So thank you very much. I'm happy to be with you to share with you the experience which we are having at Entebbe Hospital, one of the Ugandan hospital which has been at the forefront of fighting COVID. So we are going to use this experience of our hospital, relating it with other regional referral hospital, to share how we have gone through this COVID pandemic. Next. So the outline, next slide. The outline basically of my presentation, I'll give you a picture of how the COVID has been relating with our neighbors. I'll look at the Ugandan health system, then how we are using the system thinking as a strategy in managing COVID. I'll look at the algorithm which we have been using as a country to manage COVID. Then the hub system, which Professor has been sharing with you, which has been very critical in our managing and diagnosing COVID. Then we have to ensure that other health service systems continue, because we also have other illnesses. It's not only COVID. What are some of the enablers, challenges, and the future developments? Next. So when we look at the most hit countries worldwide, I think USA, India, Brazil, Russia, Argentina, these countries have had really quite big number of cases and quite a big number of deaths. When you compare it with our countries in Africa, next slide, you find that in Africa, basically, South Africa, Morocco, Egypt, Ethiopia, and Nigeria have been some of the countries which have been top on the list. The numbers, if you compare them with the world global hit countries, I think our numbers are less. Professor tried to highlight why people are saying in Africa it's not as bad as how it was. Even the deaths, when you look at the deaths, South Africa has quite a big number of deaths. But when you compare it with US, I think we still have less numbers. Now, when we zero down to our East African region, the next slide, Now our region, you find that we have Sudan, Ethiopia, Kenya, Tanzania, Rwanda, Congo. These are some of the countries which surround Uganda. Next slide. When you look at the trends within our countries, you'll find that Uganda, just as Professor showed you, the cases we are having presently and the deaths we are having and those which are recovered. If you compare it outside, you may really doubt whether these are the numbers we are having. But these are some of the cases we have seen as a country, and some of these cases have been managed in Entebbe Hospital. Next slide. So when you look at our health system runs away right away from the village to the regional referral. Down in the village, a village has around 1,000 people. We have what we call Health Center 1. When we go to the parish, a parish has more people, we have a Health Center 2. When you come to the sub-parish, that is Health Center 3. Now, Health Center 1 is more of an outpatient services, and it has just, you see a patient, you give medication, and the patient goes home. When you come to Health Center 3, the nature of the health workers improves, as well as the services provided. Starting from Health Center 3, right away to the hospital, the National Referral Hospital, we have laboratory services, and the services keep on improving as we go along. So when we are managing the COVID in Uganda, we are using this health system. Health Center 1 helps us with the referral system. They identify a person who has been in the village. That person can be either referred to Health Center 2 or Health Center 4. Then when we come to the district hospital, we have over 100 districts within Uganda. In district hospitals and regional referrals, this is where we have the isolation units. We have a hub system whereby the labs right away from Health Center 1 can get samples and then are taken to the national referral where the testing is done. So this understanding the health system within the country has helped us in the managing of this COVID pandemic. Next slide. Next slide. There are many players. So looking at the WHO building block, we borrowed this as a strategy to manage COVID. There are 6 building blocks: service delivery, health workers, information, financing, and leadership. If you understand these building blocks well, it can help you create a concept which you can manage. So we looked at COVID management as a very complex system. So we had to ensure that all these players, all these items are balanced in a way to ensure that when we are managing COVID, in order to have a good responsiveness, equity, safety, and to ensure that we reach all our people within our country, we borrowed this as a concept, looking at the entire country as a complex system. Next slide. Out of that, we came up with this conceptual framework. We looked at our health system, the inner circle, and out of that health system, if you can reflect back the different health centers we are having, all those are into the health system. So we had to look at the leadership, then the resources. If you coordinate this very well, then you can manage the service delivery. At the end of the day, you can ensure that good outcomes like responsiveness and the goal of ensuring that all our people get improved health care. So we use this as a framework in this management of COVID within our hospital and as a country as large. Next slide. So under leadership, next slide. Under leadership, we had to look at right away from the ministry, the top management of the ministry, the districts, the regional areas. All those leaders had to be coordinated, even the community, with right away from the village to the parishes to the districts. These leaders had to play a governance role and a steering role. Then we have to ensure that the resources are mobilized well, because if you don't have enough resources in terms of medicines, in terms of the coveralls, you can't coordinate this COVID pandemic. Infrastructure was a very critical area to look at, because we had to understand all the facilities we have, how many ICUs we have, the equipment, how many ambulances. If we link up all those factors with good leadership, not forgetting finances, the services we are giving, then at the end of the day, we can have an improved health care. So this one, we looked at the whole complex system of managing COVID and not forgetting other essential services. So it really helped us as an institution, as a country, to ensure that the coordination is done well and we get good outcome. Next slide. So now in our algorithm of managing COVID, so right away, as professors told you, cases came from abroad, other cases were locally got within our country, then these cases had to come to the institution. So a patient, I'm showing you the triage of how we would take on this patient. So a patient enters into the facility. The most important thing which we have to ensure is proper IPC, sanitizing or hand washing. Then we'll take a temperature. After that, we'll ask questions. We had a checklist. We're using the criteria of, did that patient have any contact of coronavirus? And initially we're asking people, had you traveled out of the country? But after some time, when we had community transmission, that checklist would not work. So if a person finds himself that has one yes of those two criteria, then we'll go ahead to check the temperature. We'll check the temperature, the fever, and we had some signs and symptoms we are using: cough, the breath, the weakness of the muscles, or headache, or sore throat. If that person had at least one of those signs, then he would become a suspect. If he had nothing, we had quarantine centers. Initially, when we had started as a country, before the community transmission, we would quarantine these people, especially the people who had traveled. We got the first index case on March 21st, and we had to quarantine all those people who were not suspects. So if you had nothing of the two signs, either you don't have a contact or you have not traveled out of the country, then you're at a low risk. So we had suspects. So all those are people who had at least one of those signs and symptoms. Next slide. Next. So if that person becomes a suspect, then we'll look at the danger signs. These people, some of them would come in with very bad danger signs, especially respiration, chest problems. Some of them had mental problems like convulsions, dehydration. So if the person had any of those danger signs, we would want first of all to stabilize the person. We would give oxygen, hydrate. If the person didn't have any of those danger signs, we would remove a sample, and that sample would be taken to Uganda Virus Research Institute within Entebbe. Malaria was one of the diagnostic tests would think that probably it could be malaria, because malaria is very common in Uganda, or COVID. Now, when we remove a sample, if the sample becomes positive, we would send that person to the isolation unit. If the sample is negative, we would isolate that person and monitor the person. This is the way we are reusing the logarithm to screen out the COVID patients. Next slide. The same algorithm. The first one was for with no community transmission, and this one is with community transmission. Next slide. And after using that algorithm, we would grade our people into mild illness, moderate, severe, and the critically ill, just as the trend professor showed you: mild, moderate, severe, and the majority of our people had mild illness or asymptomatic. And the critically ill were not very many. Next slide. So out of that, we had a protocol of managing these people. In Uganda, in Africa, COVID, we don't have a specific treatment. We are doing supportive treatment. Those who are symptomatic, mild symptoms, would give them supportive treatment, basically nutrition, calm down the temperature by giving paracetamol, and vitamin C. Vitamin C was very critical because we were using vitamin C to repair the membranes of the lungs and the respiratory system. So for mild illness, basically we give them good feeding, counsel them, because the majority of them had a lot of mental illness. They were depressed, they thought that they would advance to severe illness. So we would give them a lot of counseling, support, and paracetamol. If the illness is moderate, that is the signs and symptoms are more. They have some signs and symptoms of cough. At times they would get secondary pneumonia, then would add an antibiotic. And the commonest we are giving is amoxicillin. Zinc was also supplemented, and vitamin A, especially for the children, because vitamin A is very supportive on the mucous membrane. And COVID really grows a lot into the mucous membranes, especially the respiratory system. Now in category C, this is severe disease. These are people with respiratory distress. We'll give them oxygen therapy and then would advance to stronger antibiotics. Azithromycin and amoxicillin were the commonest drugs we're using here in Uganda. But at times some people would come with very severe illness, would use intravenous ceftriaxone. Zinc and vitamin C were part and parcel of that management. We have had few critical cases, and these are basically people who have comorbid factors. In Uganda, people who had comorbid factors, people who are above 60 years, people who are diabetic, people who have HIV, people who have other diseases like TB. They really advance to severe illness. We give them IV intravenous fluids, additional treatment like dexamethasone, and would monitor them critically. But these we have got quite few numbers, and mainly these people would be managed in the ICU within the country. Next slide. Now we had a hub system. These are the laboratory which played a very critical role in managing. We don't have many laboratories within our health system, so what we would do, we would use the central laboratory. Uganda Virus Research Institute as the national laboratory for testing viral infection. So out of the health centers within our health systems, we would use the hub system. Riders would collect samples from the various health institutions, package them very well, and these samples will be taken to a central laboratory for testing. That is the hub system. This hub system helped us so that those areas, those regions which don't have proper laboratory system, the hub system will help in one way or another. And it helped us to ensure that at least patients are not moved from one region to another, but the samples could be removed, and it would help us to manage some of these cases well. Next slide. Next slide. That's a map of Uganda. Where the star is, that is where we have our central laboratory, but samples would come right here from the north, and then they would move either through a vehicle, and then that hub system would help us to ensure that some of these specimens are moved into the central laboratory. But as the numbers kept on building, the central laboratory had to establish sites, smaller labs within the region to ensure that some of these samples are tested there. This one helped us, especially to rule out certain other diseases from COVID as a country. Next slide. We had to ensure that other services continue, because as a country, like as a hospital, we had other services which are going on. This health system, because COVID is on one side, but the other essential services, maternity, the newborns, the communicable diseases like malaria, diarrhea, pneumonia, and these ones even have had a lot of mortality and morbidity within this season. Routine immunization, reproductive health, family planning, the chronic diseases like TB and HIV care, we had to ensure that they move. We had to balance the services, COVID on one side, as well as the health systems on another side. COVID spread so much, we had to use the same human resource, same resources to ensure that we continue running COVID as well as managing other services. It was quite challenging because we're using the same human resource, the same resources, and COVID was a new pandemic coming into a health system. And remember, these other people were offering these essential services could also get infected. So we had to take precautions to ensure that the health workers continue providing the essential services as well as not infecting the population which comes to gain those services. How are we doing it? Next slide. Because the balance couldn't go on very well, some of these services were delayed. So we had to use the system thinking. How do we use our governance and coordination to ensure that people continue with the COVID management as well as the essential services? We had to look at which are the priority services we had to offer, because we are using the same budget. So we had to look at continuing to offer the prevention of communicable diseases, maternal services, in the same line as managing COVID. The medicine flow, the workforce, how would you manage dividing the same workforce and continue monitoring? And we have to communicate to the community to tell them there's continuity of these services, but be aware that there is also this illness, this very big pandemic of COVID. So the continuity of the services in line with COVID, we have to balance the two. Next slide. Next slide. So that is a linkage which I was showing: essential services, the entry points, the community, and the players within that. It was really a complex system to manage and was quite difficult in getting all that done. And we are continuing, the struggle still continues to ensure that we move on as a country. Next slide. The next slide, please. So these are some of the risks which came up. The demand side, people were fearing to access the health services because there was COVID there. We had to put their measures. People started going into private to use out-of-pocket spending, the challenges of transport. On side of the supply as health services, we had to postpone some of these services. Some centers were turned into COVID managing centers, the supplies, and we had to stretch our workforce to ensure that we offer these services. Next slide. So these are some of the emerging risks. So we have to ensure that proper usage of IPC, the social distancing, and the crowding at the service provision points, which was not easy to manage. Next slide. So what helped us basically? We want to appreciate the country, the political support, the technical people, the doctors, the nurses, the scientists, especially in the lab, the policies and the guidelines and the standard operating procedures, the teamwork amongst the staffs, the technical and the support, then the functioning health system, the governance was very supportive. Next slide. The challenges, the workload, especially the workforce. In Africa here, people still have some COVID myths, negative. They think COVID is not there. It's something rare, and they think, is it this normal flu we are always having? The poor referral system, the funds, and some people had started politicizing the COVID. Then the mental breakdown. Some of our cases, especially those who came in imported, had mental breakdown because they thought they are going to advance into severe disease, and we had limited ICU to handle the severe diseases. We are lucky that we have not got very many severe illnesses, but we are worried just in case we progress into that. We have really limited facilities to handle that. Next slide. The future, I think Professor touched on this. There's a lot of research being done, and I think it was very elaborated. One area which is really interesting, scientists are trying to find out if we can use plasma to manage those people who had exposure of COVID. Could their blood be used to manage others? Then the local industries, we started making some of these things, coveralls, masks, and I think the international internet working in the management of COVID has been very something which has come up, and I think we have engaged the private practitioners into this fight of COVID, because as a public institutions, we cannot manage the fight of this pandemic. I want to thank you so much. I want to acknowledge Ministry of Health, Uganda Medical Research Council, my staffs, and WHO for this support. Thank you very much.
Excellent. Thank you, Dr. Mwanga. So now I'm going to start asking some of the questions that might be for either one of you that have been coming in. I'll start with the ones that have gotten the most thumbs up, so the most likes by other people, and we'll go from there, okay? The first ones that have gotten a lot of thumbs up is asking about PPE. So do you have sufficient PPE supply, and for healthcare workers, but also for regular citizens or for school children who are going back to school now?
Yes, thank you very much. I think I would say we don't have enough personal protective gear. We have enough for the staffs, but we keep on getting shortages here and there, and we limit the number of people entering into the ICUs. For the community, I would think we give them basic protective measures, hand washing, usage of sanitizers, but as a country, we still have that struggle. Locally, as I've told you when I was closing up, we're encouraging our local industries to manufacture, because we had a challenge of masks. Now locally, they are being manufactured, and I think it's no longer a big problem. But we are having the overalls for people who are going into the ICU. That is quite a big challenge, and we hope that in the near future, as a future plan, we may get some way out of it.
Okay, that's great. So the masks that are being manufactured locally, that has started now?
Yes, it has started.
Okay, that's cool. That's very cool. All right, the next question that did get a lot of likes as well is asking about payment for, are there user fees for COVID testing and for treatment? And then what do you do if a patient cannot afford it?
I think the treatment is free, but of recent, because the numbers have increased of even people who think that they need to be tested, the government has put there some money, some testing for people who want to test to find out if they have COVID, because ideally the kits are quite expensive. We don't have local anemia. All the people who have contacts, we test them free of charge. But if somebody just wants to find out his status, then I think we can do a bit of cost sharing to ensure that we have a constant supply of some of these kits.
Okay, and are community health workers being used to go find contact tracing and bring people for testing?
Yes, we give people information. Information is given. We use different medias of communicating. Radios are the commonest medias we are using. Televisions, we also give people. And we also use VHTs. These are village health team members. I remember that the other slide I showed you. So they go out in the community, they give people information. Then the community, the people can come into those different facilities, and then the testing can be done. And then using the hub, the samples can be brought to the central laboratories. So we use the health workers as well as VHTs.
Very good. And in the comments, somebody had posted that if the patient needs to do cost sharing, like if they don't qualify for the free testing that you spoke about, that it was about $65 of a charge for cost sharing, which I was just going to comment to the group, that is very close to what it is in the United States here. Ours is also, it's about $65 for patients who do cost sharing here. And the only patients that we do free testing for are the healthcare workers and their family members. So anybody else would have to do cost sharing, and it would be the same price. So I thought that was kind of interesting. Some other questions that have come through have to do with your testing turnaround time. I know you have point of care testing for antigen, so that's obviously immediate. But what about your other testing? What's the turnaround time?
The turnaround time, we give it about 24 to 48 hours because many times the samples have to be transported. Dr. Mwanga has told you samples come from different places. So if you put in the time for transportation and all that, so we give it about 24 to 48 hours. At the beginning, there was a lot of pressure to provide results in less than 24 hours. But of course, sometimes when you push too much, you can even make some mistakes. So that's averagely how we are, the time we are giving. We can do it sooner than that, quickly, and many times we have done that within 24 hours. We provide the results. Now these results, when we do them, they go to the center where a certificate is provided that has a code so that we don't have any forged results, because these days they are also required for travel. The point of care, we are trying as much as possible to have point of care. Antigen is one of those we are proposing. It's not yet rolled out. It will be fast training, but ensuring that the results we get match very well with the PCR. But that's the way forward that we want to be, either PCR or antigen point of care. So, so that's what we're doing. We do as much as possible, work fast to provide results quickly. The private labs also that have opened up are also helping us. You could have results quicker if you go there, especially those who want to travel and all that. But we make an effort to provide results within 24 hours.
Very good. For the travel certificate, is that to travel in between districts or in between countries?
Between country airlines, between countries, airlines require you to have a COVID test within 72 hours. So that's for people who are traveling out of the country.
Mm-hmm. Okay, great. And again, just for the group, for comparison, here at USF, we do have the point of care antigens, so we have those results in 15 minutes. But then for PCR, we have two options. We have the GeneXpert machine that can do PCR. It takes about 2 hours, and we do that for some high-risk patients. But of course, the cartridges, the supply is limited and they're expensive, just like always for GeneXpert. So we, like for example, we only have 80 in stock right now, and so we are very much trying to limit that. So then for the rest of our PCR, we also have a 24 to 48 hour turnaround time because we have to transport that to the other side of the state as well. So kind of pretty similar, really, with you guys. Another question that came about testing is, are you worried about false positive or false negative rates on testing? And do patients trust the results?
Yes, false positive or false negative. I mean, discrepant results sometimes do occur because we're dealing with a living virus. We have had people who have tested in one lab and in another, and they have different results. That could be genuine because of the virus. If you test one and you still have viremia, it's positive. After a day or two, you may be, the virus has come down. So sometimes that's possible, or you have tested before the virus is really high to be picked, and you're negative, and then the following day you're positive. So that's possible. But also we are discussing about these cutoffs. We are using real-time PCR, which uses CT value, cycle threshold, and we are discussing that if we have results that are very near the cutoff, borderline, it's better maybe to say the results are inconclusive, let's repeat them. It's possible in a lab to have some of those results that are difficult, that are borderline, and those can cause also problems. But as you know, in the lab, occasionally false positive or false negative can occur. We are dealing with the PCR, but we are trying to ensure that we give good results. We are rolling out external quality assurance. For us, our lab here is enrolled into the WHO external quality assurance system. So we try to put in measures to reduce on that, but that's a possibility.
Okay, great. Back to some of the timeline that you showed us, Dr. Kalibu, about mitigation effects and measures. How did people react to closing markets and curfews and schools?
Of course, it's painful. It's painful. It's not easy. At the beginning, everyone was so scared. We were seeing all the stories in Europe, in Asia, and America, the death and all that. People were very scared. So they very embraced it. They embraced it enthusiastically. People were scared. They had no problem. But of course, now with the time, taking time, people are getting tired. It's affecting the economy, the families. It's affecting people are getting even psychological, mental issues. The children not going to school. The churches being closed. It's getting tough. That's why the government has started opening slowly. It's not fully open. There are a number of activities that are not functioning as yet. But yes, the opening has started. On the other hand, I think even people started unlocking themselves even before the official lockdown. So it's very difficult to sustain over a period of time. Now we still have curfew, 9 p.m. Curfew starts, but if you go out cities and towns and roads, the cars are still moving. So it's not easy to enforce at this stage.
Yes, we're having the same issue. At first, enthusiasm, and now people are just tired of it, Dr. Mwanga, you had talked about a couple of times referencing the mental toll that this is taking on patients. And we're seeing that too, increased rates of depression and suicide and substance abuse. Is that happening, you think, because of the economic impact of the curfews and shutdown, or is it more because of being scared?
Yeah, I think it is more of economy, because many of the people we got who broke down were people who returned from abroad. Some of them were being deported, and when they returned, then we had to quarantine them. In the process of being quarantined, they got depressed, they got a lot of, anxiety because they had gone outside to work. Now the whole situation changes around. So when they come here, and then we said we had to quarantine them, then many of them became depressed. Other people who returned voluntarily, and we had to put them into the quarantine center. Ideally, as a country, people had to look at to pay. There was some money attached to that period of time when you are quarantined. And many of the hotels were not willing to take on people who are COVID, suspects. That means the costs of maintaining that person within that area were quite big. So even that part of it depressed people. They couldn't see their families. So we had a lot of challenges. Even the ones who were positive, comparing it with the international picture which was going on, many of them thought that they were going to advance into severe disease. So ideally, they had a lot of depression. And when it came to the truck drivers, many of the truck drivers lost jobs. As soon as they test you, you are positive, then your boss just tells you off the job. So you have lost a job, but you're under quarantine for over those days when we kept them here. So I think that those are some of the challenges which really affected people in one way or another. Then we also had children who got it. The parents were depressed. They were looking at what is going to happen. The worst part of it came to the pregnant mothers. We had some pregnant women who tested positive for COVID. So they were worried that probably my newborn is going to get COVID. These are dilemmas which we really had. So throughout the pregnancy, some of them became depressed, but luckily enough, we had, I think there's 1 or 2, we had to carry out a cesarean section when she's COVID positive. But along the way, the good part of it, they delivered babies who were negative for COVID. So it was just a mixture of quite many people.
Mm-hmm. Yes. And Dr. Mwanga, how are your healthcare providers and environmental services and other staff in the hospital how are they doing with the caseload and the mental toll?
Yeah, I think it was quite challenging. For the first cases, I remember the first case we had as an index case. Everybody was at a panic, all our health workers. We didn't know how to handle. We didn't have proper protocols of what to do. So we are just comparing with our international friends, then say, let us use this protocol to manage the patients. So all the staffs and all my staffs, we had to keep them within the hospital because they were contacts of the patients. So they were tortured psychologically. Their families told them, you stay within the hospital. You know, some of these were a bit challenging. So I realized there was also a mental torture of the staffs within the hospital. Worst was the management, because coordinating these people, reassuring them, team building was not very easy. So every week we used to have 2 meetings to keep on giving these people hope. And after 2 weeks, we kept on checking our health workers, those who turned positive. Then after a period of time, some of our health workers were exposed and they turned positive. That even made the situation worse, because they knew that now even them, they are exposed. So it was quite challenging, and it's still a bit challenging in one way or another.
Yes. I think I was there in February when you guys started those meetings. I remember being in the corner for one of the meetings. So it was very good. Do you still have the healthcare workers stay in the hospital because of their contact? Yes. So they're all sleeping there.
Yeah, they sleep within the hospital.
Oh, wow.
Ideally, the entire hospital closed. It's managing COVID. Other services were suspended.
Okay.
We carry them out as outreaches. But within the hospital, the moment we got the COVID patient, some patients discharged themselves. You know, they had to run away because they knew the hospital has, you know, it's now labeled as a COVID hospital. Yeah, but we are planning to start opening other services soon.
Okay. And then I know that we're past time, but I was going to ask one more question about your treatment protocols. So they're actually also very similar to what we have. We don't have, you know, we have some clinical trials for monoclonal antibodies or plasma donation. But outside of clinical trials, our protocols are also similar with yours, except there's 2 things that I noticed that were different. One is that we also use vitamin D, because there's evidence in other respiratory infections that it helps the lungs fight away the vitamin D. So I was wondering if that would be available on your formulary to add. And then there's also been a lot of reports of COVID being hypercoagulable. So for patients who are in the hospital, we do give them prophylactic anticoagulation with heparin or enoxaparin. If they're outpatients, if they're at home, we don't give that, but in the hospital we give that. So would either of those things be available on you guys' formulary?
Yes, I think vitamin D is available, even heparin. But we need to, you know, we have different pillars. We have the case management pillar. I think I'll share with them this, but vitamin D is available. And heparin, but we always give it for other conditions, not basically for this COVID. But the good thing here, our cases have not really been that severe, apart from a few who have been critically ill, and even some of them have succumbed that we have trained here and there. But the majority of the cases we have seen advance into critical diseases have been having comorbid factors, either diabetes, cancers, age. We also thought that pregnancy was also a comorbid factor, but many of our pregnant women have made it. And HIV, because HIV is quite, the prevalence here is high, many of our HIV patients who have not really been on control, proper medication of ARVs, have advanced into severe disease. So the majority of our people have been between moderate and mild illness.
Yeah, that is fantastic. And then the very last question, because there's some additional ones coming in, but I know that we are over time, but I kind of lump some of them together. It seems like, based on these questions, that maybe there is social unrest in Uganda. There certainly is here in the US. You guys have probably seen all the news coverage about all of the riots and protests in the US of social unrest from social justice and racism and disparities, that really COVID is highlighting these disparities, like you were just saying, Dr. Mwanga, that people who are more ill, who have poor access to healthcare, they're getting hit the hardest. Is that also happening over in Uganda? And what do you think that healthcare workers and government could do to help with that? We're struggling with it here also.
Yeah, I mean, I think here it's not. I think you have managed whoever comes into the public hospitals. Many of them have been managed in public hospitals that are open. There is no discrimination type of class or social class. So it's not been a major issue within our system here, which has been good. I mean, it's been open. Even what we've been talking about paying for testing, the people who are sick, symptomatic, their contacts and all that are still getting free testing. So because we have managed, this has been managed in a public setting, I think it has been open and free for all our citizens, and we have not seen those social challenges.
Mm-hmm. Yes, it seems like you guys are much more transparent and fair and higher equity than what we have here, which is contributing a lot to all of our protests that are happening in the US. And of course, our highest government leadership is also, not necessarily on board with all of the scientific recommendations, which I'm sure that you guys have also seen, which I think contributes when the messaging is like that.
The only time we faced it is during this isolation. Isolation, the government said, if you can afford, you go to a better isolation center. Yeah, and those who could not afford were going to the lower class, where there was less, better facilities and all that. And there were people who, of course, complained, they were not happy, and they wanted to, they were on radio and television, they have not been treated well. So we had that issue of isolation, the quarantine that was there. If you are, depending on how much you can afford, some of them went to better places than others. But now I think they're even encouraging the quarantine from their homes if you are not sick.
Mm-hmm. Yes, indeed. Okay. Do you guys have any final comments for any of us, or any questions for any of us?
I think.
Yeah, probably just to ask, how are you managing the big numbers? Because we have seen, because we always watch it on international news, you are getting many of the critically ill. Mm-hmm. I don't know why most of your cases turn into that critical illness. Is it that they report late, or I don't know?
Yes, what we're finding is actually that obesity and diabetes are the main contributing comorbidities to our cases that turn into complicated critical illness cases, for sure. And our rates of that are out of control. The obesity epidemic is out of control here. And I think that that's contributing a lot to why our patients are getting very critically ill. People want to talk about delay in care and poor access to healthcare as well, which is, again, that goes back to some of these health disparities that certain communities, whether it's based on religion or race or socioeconomic status, that they don't have access to health facilities very easily, or that the health facilities they access here are poorly equipped. They don't have trained physicians for COVID. They don't have protocols for COVID, and so they treat them like they might just have some regular pneumonia. They give them levofloxacin and they go home, and they don't do anything specific for COVID, right? And so that is, and then they stay at home and get more and more ill instead of getting specific protocol-driven treatments. So those things are happening here, contributing to the high numbers that are going on. And then we do not have a national mask mandate. I don't know if you guys have that, but we do not have it. And so people do not wear masks, and we have we moved to reopening so that the businesses and restaurants and bars are open, and you are allowed to wear a mask if you want to, but you do not have to. And that is contributing hugely to public health also.
No, I think we see and we sympathize with the situation there. I think COVID has been so much also politicized. It's also a political issue. The messages are not very clear. I think we understand the challenges that you are facing there. I mean, yeah, it's not easy.
It's not easy, for sure, and it really seems to have a lot more similarities than differences, actually. Yeah. Very good. Thank you guys a million times. Dr. Mwanga, I hope to come back in 2021 as soon as we can safely leave and travel and things like that, and as soon as the university will let me on our side, because the staff is not allowed to travel right now, or it's discouraged at least, but I hope to come back over there and see you guys soon.
Okay. Yeah.
Very good. Thank you guys.
Okay, thank you very much. Yeah.
Bye.
Bye-bye.